Hi, John Link is here with ATA, and I'm really happy that we are joined today with Andrew Watson, who is the President-elect of the American Telemedicine Association, but in his day job, he is also at the University of Pittsburgh Medical Center, UPMC, not only working in a telemedicine program, but a surgeon as well. Good to have you, Andrew.
Good to be here, John, and thank you very much. And yes, I am a surgeon at UPMC, and I also work on the insurance side of UPMC, so I get to learn how to practice telemedicine and also look at how we reimburse for telemedicine. And it's a very interesting world right now in telemedicine from a delivery side and a payment side, as you know well.
That's great. So you can do it and pay for it. I like that.
Absolutely. That's the goal, yes.
That's great. So Andrew's really added a lot to the association since he's been on the board and working, and not only as a friend, but also as a good colleague and a guy who's taught me a lot about what's happening right now in the world of telemedicine. Things are very, very active there at UPMC, and I want to ask you a little bit about that. But first, since we're at ATA and you've been very involved with the strategic plan and working on where we are, just a few thoughts maybe on your view of where the association is in the world of telemedicine and what we have to look forward to.
It's a great question, and my view is that telemedicine is essential for healthcare transformation. I don't know how we can re-envision healthcare without telemedicine. In many ways, you've heard me say this before, that telemedicine is just the natural evolution of healthcare in a digital world. And so we're headed here whether we like it or not, and of course, we like it here. In fact, we love it here. And the ATA is critical because, number one, we nucleate the issue. We are giving people a location to go to, a website. We give the world's leading meeting for telemedicine as well. Our annual meeting in Chicago next year, led by you and Peter, is going to be critical. This is the forum for people to learn about it. But also we are the purveyor of a lot of the knowledge. And we've talked about value, we've talked about outcomes, implementation, scale, and you have a long history here of leading that. And so the ATA, in my mind, is the critical fulcrum of developing how we're going to look at a different world of healthcare. Clearly, the Congress is leading this, the President's involved with this in many ways, but for us, we need to show how the digital aspect is interwoven throughout healthcare. And it's just the natural evolution of healthcare in this modern world we live in.
That's great. That's a fabulous summing up of kind of where we are at ATA and your views on telemedicine. But you not only have that, but you've got real world experience too at what's going on at UPMC, and it's fascinating that you're combined payment and providing now, as few other systems are moving as well, but you're also doing a lot in terms of telemedicine. We were talking this morning about what you've got going on in remote monitoring and a few other areas. So fill us in a little bit on what some of you guys got going on.
Sure, happy to. I should also say or disclose that I've done 500 consults myself. It's not a lot, but it was surprising how much patients want telemedicine. And I should confess, I've had 2 patients refuse telemedicine. One wanted to come to the local casino and gamble, and the other one was scared of telemedicine. Yeah, that was a good reason. And the other one was actually scared of it, but almost got into a car accident on the way down and subsequently had 3 other telemedicine visits. Wow. So effectively, I've had no one outright say no to it. And what I've learned is that the patients expect this, they want this, they believe in it. And one of the most common comments I get is, it's about time, or I guess you're catching up. And more broadly speaking at UPMC, the question that you asked is that since we both deliver healthcare and pay for the delivery of healthcare, it's a combined process that we have right now. Clearly, our roots in UPMC started with hospitals and physicians, and we use telemedicine, and it's becoming a way of life. If you look at dermatology, pathology, stroke care, certainly radiology is ubiquitous these days. But there are 2 other large components that we're seeing right now. One component is the direct-to-consumer aspect, and we certainly see for a lot of urgent care type visits this is critical. But we're also looking at post-acute care type settings and follow-up settings and primary care. And the other, which is one of my great passions, is remote patient monitoring. We believe this is the Doppler weather radar of healthcare. It's scanning our members, scanning our environment, looking for trouble, and feeding information up to the front line. And we are about a year into our journey in a re-envisioned program and platform. We have 1,000 patients on it the first year. We're just getting going. But remote patient monitoring, in my opinion, is as far upstream as you can go in healthcare. It's asynchronous, it's at the patient's homes, it's when and where they want it, and it's a very powerful technology. And we certainly view that by bringing these three pieces together of the traditional telemedicine, so to speak, the direct-to-consumer and remote patient monitoring, that we should have all the pieces together. And the net impact for us is value. What value does it bring to all aspects of our organization? And you know I'm beating a dead horse with that one, John.
But it's good. And so I know in your remote monitoring you're focusing mostly on CHF, is that right?
It's congestive heart failure, it's inflammatory bowel disease, what we call pre-palliative care or advanced illness care, and some tobacco treatment services. And we're looking at other chronic diseases right now that include pain management and COPD.
So how did you come to the decision of focusing on those areas?
We started by building a platform with a state-of-the-art vendor, but 50% of this journey was operations. And then we went to management and said, what are the problems? And the executive management gives us the problems that we need to focus on. And clearly, chronic disease management, post-acute care, long-term care, preventative care are top on our list. But COPD is a major problem because these patients are sick. They're hard to manage in the hospital, out of the hospital. And certainly in the post-acute space, there's a very high medical spend on these folks. And so we went after the sickest of the sick. And we used a Charlson Comorbidity Index. About half of our patients have an index greater than 8. And we went after the sick population trying to say, how do we bring down the total cost of care? How do we bring down the observation, ED visits, and also the readmissions? And that's where we are right now. We're just at the beginning of our journey. And
the same is true of so many different organizations. And again, as I understand it, acuity is certainly an issue, cost is certainly an issue, but it ends up, at least for the patient, is quality. So that's a nice combination. And I'm excited to hear the results, and hopefully we'll be publishing some data soon, because that's some of the things that ATA tries to do, is get out this information to some of the other folks.
That's our plan, and this is all about value. It's the cost and the quality. And a lot of the metrics that we gave you, or I just gave you, were based on cost. But on the quality side, we're seeing interesting results so far, in that the average age of our cohort's about 74. Our compliance is over 92 to 94%, which means that every question they were asked or bioparameter they were supposed to gather was done. And that the satisfaction's also been very high, averaging around 90%. And so we're learning. I mean, we have a ways to go, we know that. There are other experts out there. I'm talking to Christy Henderson yesterday, or Laurie Poole in Ontario. There are many experts out there right now, and we look to really help our population. And I should say that remote patient monitoring is really a population health tool. It may be more of an intelligence layer underneath, but it's very patient-facing. And at some point, I suspect it may be commoditized. You can buy peripherals in the Apple Store or Target or Google, whatever else exists these days. And patients are going to come to our clinics and saying, hey, what does this mean and what are you going to do with it? And right now we're trying to say, well, figure it out. But in the future, it's going to be truly a connected environment.
Yeah, that's great. Well, Andrew, it's going to be a lot of fun working this next year with you, actually next couple of years with you, and I look forward to not only the results of a lot of the work that you're doing there, but also some of the great things we're going to do together at ATA. So thank you.
And thank you, John. And I should also say to the members at large, the work that John's done with the board on the strategic plan will be very impactful, and I'm just so happy to have that process up and going, and we appreciate all that you and Sabrina have done. And it's a fabulous journey for us, and there's a lot that we can do for healthcare of the future, and we're going to be right in the middle of it.
Thanks.
Thank you very much.
Thank you.